applause for a great talk. And now I'm going to have Dr. Susan Promes, Editor-in-Chief of Academic Emergency Medicine Education and Training, to introduce today's Education Plenary abstracts.
Thank you, Dr. Beam. It's my pleasure and honor to moderate our top educational abstracts of the year. Each abstract underwent an objective, independent peer review process, and the top 8 were selected as this year's plenaries. Today, the second half of the abstracts will be presented. I'd like to invite our first presenter to the stage at this time. Our first presentation is entitled Comparison of Performance Data from 3-year Emergency Medicine Residency Programs and 4-year Emergency Medicine Residency Programs, presented by Dr. Micheal S. Beeson from Summa Health System.
Well, good morning. My name is Mike Beeson, and I will be presenting data from research that was done by the American Board of Emergency Medicine. Today, I'll be presenting information related to a non-controversial topic of comparison of performance data from emergency medicine 1 through 3 and 1 through 4 programs. I have no conflicts of interest. I do have a duality of interest, however. I serve on the board of directors of ABEM. I'm also a program director of a 1 through 3 program. This project was considered exempt from human research by our IRB. All of us in this room know and understand that from the very beginning of our specialty, we have had multiple training formats. And they've been confusing at times for a number of people, including ourselves, with it. There's, at different times, the controversy has risen up, and there's been many qualitative articles related to the benefits of one format versus another. But to date, there's really been very little quantitative data that has helped to explain the differences between the two formats. Laura Hobson and her group in 2016 did have an article that looked at program director preferences in terms of the formats, and the principal finding was, unsurprisingly, that program directors tended to favor formats where they did their own residency at, as well as the format that they were actually leading within the program that they were the program director. So the methods for this study: retrospective descriptive study. Multiple data sets were reviewed. Only residents in U.S. categorical programs were included. International program residents were excluded. Combined training program residents were excluded. And the level of training was assigned by their program director. The measures that we looked at and used include the Spring 2021 Milestones ratings, in-training exam scaled scores, qualifying examination scaled scores, qualifying examination pass rates, oral certification examination scaled scores, oral certification examination pass rates, and then finally rates of program extensions. In terms of milestones ratings, we used milestone ratings from the spring rather than the fall. We know that there tends to be greater variability of milestone ratings, especially for PGY1 residents in the fall compared to the spring. We also used milestone ratings using Milestones 1.0. Milestones 2.0 had not been incorporated yet. If you compare the two different formats, there is gradual progression of scoring with each year level. And if you compare residents in each class within each format, EM1's 1.59 for 1 through 3 programs versus 1.57 in 1 through 4 programs, p-value of 0.23. For residents in EM2s and EM3s, EM2s 2.60 for 1 through 3 programs, 2.47 for 1 through 4 programs. And then for EM3s, it was 3.45 for 1 through 3 programs and 3.27 for residents in 1 through 4 programs. For EM2s and 3s, those values were statistically significant. I'll have you recall that for milestone scoring, it's scored on a scale of 1 to 5 in 0.5 increments. Level 1 is the expected performance of someone who's graduated from medical school. Level 4 is the hoped for competency level for someone graduating from a residency. For in-training examination scores, comparing the two different formats, 1 through 3 programs tended to do a little bit better. EM1s scored 70.2 in 1 through 3 programs and 68.2 in 1 through 4 programs. EM2s scored 76.6 in 1 through 3 programs versus 73.8 in 1 through 4 programs. And then EM3 scored 79.7 versus 78.1 in 1 through 4 programs. We did not compare terminal residents from each program, EM4s versus EM3s in 1 through 3 programs. Qualifying examination scores, candidates from 1 through 3 programs scored 83.55 compared to 83.00 for candidates from 1 through 4 programs. You can see the p-value there. Passing rates for the qualifying exam, candidates from 1 through 3 programs had a pass rate of 93.1% compared to a pass rate of 90.8% for candidates from 1 through 4 programs. For the oral certification examination, candidates from 1 through 4 programs tended to do a little bit better, 5.67 versus a 5.65 for 1 through 3 programs. And for oral certification exam pass rates, overall, candidates from 1 through 4 programs had an overall pass rate of 96.9% versus 95.5% for candidates from 1 through 3 programs. For rates of program extensions, ABEM does keep very close tabs on residents within training programs when they need to extend their training in order to ensure that the right individuals are entering into the overall certification process. And you can see it's kind of all over the board. It's difficult to come to any conclusion. In 2020, there was statistical significance in comparison of 7.1% versus 11.6%. We have not gone into the data in terms of what might explain the greater increase in delayed completion in residents from 1 through 4 programs compared to 1 through 3 programs, at least for that particular year. And so performance data from physicians in different training formats does vary, at least to some extent. The data show progression in both formats, both in terms of tests as well as milestones. Candidates from 1 through 3 programs tend to have higher qualifying exam performance, and candidates from 1 through 4 programs tend to have slightly higher oral certification examination performance. So I'd like to thank members of the working group that worked with me, including Melissa Barton, Wally Carter, Diane Gorgas, Marianne Galshi-Hill, Kevin Joldersmall, Earl Reisdorf, and Sally Santon. So in conclusion, performance data from different training formats vary. Sense-making of the results requires a community-wide conversation. There are additional considerations as well. Categorical conclusions are subject to confirmation bias. Probably each of us in this room have our own preferences as far as what we know is a better format for a program. And it's difficult to look at data without that confirmation bias having some kind of an effect. And then finally, additional study is needed before decisions about an optimal format can be asserted, especially regarding practice performance. And so thank you. I'd be happy to entertain any questions or comments especially.
We are now open for questions. If you'll come up to the mic, introduce yourself and where you're from.
Hello, my name is Tom Yang. I'm from Medical College of Wisconsin. Thank you for a great presentation. I guess I just had a question. I don't know if you had any other factors looked into when you assessed the PGY and the 3-year programs and 4-year programs, except for the type, like number of hours in emergency medicine, blocks spent, or any other factors that looked into it instead of type itself to see if there's any correlation on the passing rates and other stuff.
No, we did not have that level of detail available to us. We looked into the data sets that ABEM has and controls.
Good morning, and thank you for a really interesting presentation. I'm just wondering, do you have any information on how well that they were test takers coming into the program? Meaning, is what we're seeing, which are relatively small differences, kind of dwarfed by sort of their score before they approach their residency?
You know, as we were brainstorming this particular study, that was a comment that was brought up. In other words, it would be interesting to know if they did score well on step 1, step 2, and if that followed through with that. That's an entirely different study, but it's something that would be interesting to follow through with. Yes, I agree.
Hello. Colin Rader, I'm with Kaweah Health. Question, did you guys have a equal distribution of academic versus community programs? And then 2, did you guys look at whether or not these programs had graduated responsibility or not?
We did not separate out the data from community-based versus academic centers, university centers. As you know, that tends to be self-reported, and some community teaching centers are hybrids with university as well, so I think that would be difficult to tell. And in terms of graduated responsibility, we wouldn't know from the data which programs had that.
My question is, the expectation is the residents will improve each year. Did you, when you compared EM 1 through 3 senior residents to EM 1 through 4 senior residents, did you compare those?
We did not compare the terminal year from each. It did not. That would be interesting to do, though. It should be fairly simple and straightforward also.
Because I wonder if, the expectation is that you're going to be... The expectation is that you're going to be improvement for every year. So the expectation for in a 1 through 4 program as the EM3 should not be the terminal year at that terminal year level. However, at the 3rd year in the EM, or a terminal year in the EM 1 through 3 program, you are. I think it would be very interesting to look in your terminal year if there's a difference in those performances.
Yeah, I agree. I certainly don't disagree. I had mentioned the issue with confirmation bias, and you could argue based on the qualifying exam results that and in-training exam results that residents from 1 through 3 programs do better than residents from 1 through 4 programs. And if you tend to favor 1 through 3 formats, that would be your evidence. At the same time, if you run a 1 through 4 program, I would think you would also argue that because the curriculum is spread over 4 years, well, of course, residents are going to progress at a little bit different rate compared to residents from a 1 through 3 program. And so based on your confirmation bias, I think you can use the same data to support either conclusion. So.
We'll take one more question.
Yeah, Dan Martin from Ohio State. Very nice presentation. Just a question. As I look at your data, even though you didn't directly compare the terminal scores for in-trainings and things like that, it looked like the data suggested that the 3-year folks did better in years 1 and 2, but comparing that 4th year to the 3rd year, the 4th year folks did a little better than the 3rd year folks, yet on the qualifying exam, the three-year graduates did a little bit better than the four-year graduates. So it kind of switched a little bit. Any thoughts about that?
Yeah, you're absolutely right. When you look at the terminal years for the in-training examination, year 4 residents did do a little bit better than the year 3 residents from a 1 through 3 program. And then the qualifying exam, that difference tends to kind of fade away. I don't have an explanation for that. I think that's something that the specialty will need to continue to take a look at.
Thank you, Dr. Beeson, for a really good presentation. Our next presentation is titled Racial Bias in Medical Student Standardized Letters of Evaluation, presented by L.A. Alvarez from Stanford University.
Hello. My name is L.A. Alvarez, and I'm the Director of Wellbeing at Stanford Emergency Medicine. I'm really honored to present the work of our team that's highlighted in this slide on the racial bias in the Standardized Letter of Evaluations, or the SLO, for the emergency medicine residency applications. So those who identify as underrepresented in medicine face multiple systemic barriers, including bias and discrimination in medical education. Research has shown that bias exists in many ways. This includes the medical school admissions process, which serves as a gateway into careers in medicine. Subjectively, underrepresented students in medicine note discrimination in the use of ethnic and racial stereotypes in clinical grading. URM students receive lower clerkship grades than white students in medical school. Even the descriptors used in medical student performance evaluations, or the MSPEs, are different for white students compared to URM students. White students are more likely to be described in their MSPEs as outstanding, exceptional, and best. On the other hand, Black, Asian, and Latino medical students are more likely to receive words like competent as a descriptor. The effects of bias undermine diversity in medicine efforts in our specialty. So the Council of Residency Directors in Emergency Medicine, or CORD, developed the Standardized Letters of Evaluations as an example to create a more evaluative and stratifying assessment of medical students during their EM clerkship rotations. And we have several assessment experts in this room today. Prior research has illustrated the presence of bias, but studies primarily focused on gender. To date, there's no data on the presence of racial or ethnic bias in the SLO. So our study aimed to assess whether there's a difference in each of the SLO domain for underrepresented in medicine versus non-URM students. Now, while this study did not investigate specific factors contributing to bias, we infer that bias will exist if the scores are different between the self-identified URM students versus those who are non-URM in their SLO. This was a cross-sectional study of EM-bound applicants across 3 geographical distinct U.S. training programs during the 2019-2020 application cycle. They represent California, Chicago, and Florida. We used descriptive and regression analyses to examine the differences between URM students and non-URM students for each of the SLO components. So for those of you not familiar with the SLO is a composite evaluation completed by the clerkship team after a student finishes their EM rotation. The SLO components include the grade, the assessment of 7 qualifications of EM, global assessments, and then the predicted rank list position. Of the 3,759 combined applications from the 3 distinct sites, we have 2,002 unique applications that met inclusion criteria. This comprised about 55% of the applicants for that academic year. And 382 of the students, or 19%, self-identified as URM in the application. So for reference, here are the 7 qualifications of EM. Our assumption is that each of these domains should be independent variables that contribute to the composite score of the final grade, the global assessments, and also the rank list position that's predicted. Again, for reference, here's the section for the global assessment and the rank list. And here are our results. We found that underrepresented students in medicine had lower average scores in the 7 qualifications of EM questions, the final grades, global assessment scores, and rank list positions. We also found that of the 7 qualifications of EM, which as expected counted equally for non-URM students, unfortunately for those students who are underrepresented in medicine, it didn't matter how hard they worked. It didn't matter if they were able to work in a team or communicate in a caring manner to their patients. Only what counted towards their global assessment and rank list were whether they had a strong commitment to EM, whether they could develop or justify an appropriate differential diagnosis and plan, and how much guidance did the evaluators predicted would they need during residency. And if they got this guidance, would they be successful? We also found that one of the 7 qualifications of EM, specifically the commitment to EM, was further weighted more for URM students than non-URM applicants as a predictor for their final global assessments score. Again, evidence of commitment to the specialty was weighted more for URM students compared to non-URM students. And so in conclusion, our study demonstrates a difference in SLO scoring, with URM students receiving lower scores than non-URM students. The 7 qualifications of EM also had variable weighting for the URM students compared to the non-URM students. And with USMLE Step 1 now being pass-fail, SLO will have higher weighting in the interview offer decisions and in the final ranking decisions. And so our findings suggest the presence of bias in the SLO, which needs further investigation. At the Cord Academic Assembly in San Diego last month, they announced releasing the eSLO 2.0, and it appears that several of the assessment components that's discussed here will still be part of the new SLO. Again, I'm happy to answer any questions, and really thank you to the team here. I'm honored to present this on their behalf, and thank you for your time.
Any questions? If you could please move to the microphones, appreciate it.
Hi, Ellie. Cheryl Heron, Emory University. So, knowing we have a problem, which I'm not surprised by, what are we going to do?
Thank you for that fantastic question.
I know.
I love it. What I'm hearing here is that the entire room here is tasked to figure out what we need to do to address the bias that exists in several layers of the admission process. So specifically, Dr. Santon talked about assessments and how we keep on kicking the ball. Perhaps the moonshot here is to see that whatever assessment we develop, we can hope that bias is included in the way that we look at things to prevent certain groups to be marginalized further and preventing them to be successful in medicine. Thank you.
So I was curious, and I look forward to you all looking at the comments, right? So I think the comments are going to be really interesting between URM and non-URM, and maybe using like natural language processing or something. So is that the next study that you're going to tell us next year?
Thank you. So the question is, I love these questions. The question is, did we look into natural language processing and evaluation of the biases. We did not for this cohort. We had multiple other studies, including gender studies, and we even found that the scores are also variable for those. I think that's a great work to be done. Folks at Northwestern has done some work with Dr. Danielle Miller, for instance, leading that study in the past. I think for the future, I think that will be very important. And machine learning could probably be employed as well so that we can understand like these biasing languages. Certainly, I think an earlier step, as Dr. Daren asked earlier, what can we do? Perhaps in our medical students' performance evaluation or even in the eSLO, we can standardize the content that we're going to be including such that every student is being evaluated on key things as opposed to when I was assistant program director, you can tell that certain programs will just kind of comment on certain topics versus like, the weighting for the agentic components and also to their competency stuff. So I think making that fair for everybody, standardized, will be very helpful. Please.
Jessica Kastner from Washington, D.C. and Grand Island, New York. Thank you so much for this really insightful and important presentation. The expert emergency nurse has such a critical role in the emergency medicine residency training, particularly when the attending has an untenable workload. Can you comment as to how you envision future emergency nurses in interdisciplinary environments helping with this evaluation and how that may mitigate or exacerbate bias?
Oof.
You're getting all the easy questions.
I love it. Bring it on. I think that's a very important point. And what I'm hearing here is that how can we incorporate other team members in the healthcare system to help assess our learners so that they are prepared for when they become an attending. That requires a lot of bias training. Like as part of the education education subcommittee of the inclusion and equity committee and also ADIM, we've launched these like implicit bias training. Again, shameless plug, we have another one this afternoon. It takes a lot to train ourselves here. I think it's also, as you can imagine, there's a different system that we would train our nurses, for instance, including some restrictions perhaps with so we have different levels of leadership. And so just making that clear, I think it's a little bit tough. What I'm seeing from other people that may work is having like a multidisciplinary like simulations training so that it's talking about psychological safety. It's a lot easier to fail and learn from each other when it's a smaller group. And then perhaps we can use the language that we can communicate there and see that transferred into something written objectively for the evaluations. But you're right, I think right now a lot of these, most of this, if not all of them so far that really matter are from physicians only and perhaps may not prepare our learners for when they go back to the workforce. Yes, please.
Good morning. Thank you for that presentation. I'm Tracy McIntosh, University of Central Florida. Did you have a sense in the data that the diversity and the representation of the slow writers had an impact on the grades? Thank you.
Thank you for that question. We looked at the gender. We did not look up the race and ethnicity of the letter writers. As you can imagine, you don't disclose that when we write the slow. And even when we looked at the gender, we had to make some assumptions based on names, so we had to Google them, look up their pictures, that kind of stuff to figure out their gender. So I think it'll be hard to do, and sounds like an opportunity here for somebody to take on as a study. Well, thank you so much.
Thank you again, Dr. Alvarez, for a great presentation. Our next presentation is entitled, Are Residents at For-Profit Affiliated Emergency Medicine Residency Programs Underpaid? This will be presented by Jared Lassner from the University of Chicago.
Thank you for the introduction, Dr. Promes. I'm honored to be here today to talk to you all about for-profit affiliated emergency residency programs. I assure it's going to be another non-controversial topic. So we have nothing to disclose. So before I get started, I want to make sure I define this term for-profit affiliated program. I'm going to be using it a lot today. So what we meant by it is a program that is sponsored by a for-profit hospital or a program where the hospital where the highest number of months are spent over the duration of the program are at a for-profit hospital. So why did we even bother to create this definition? Why is this distinction important? Well, as I'm sure everyone in this room is aware, recently there was a workforce study that came out that suggested there would be a surplus of nearly 10,000 emergency medicine physicians in America by the year 2030. This is going to have profound effects in the field, and it already is having profound effects in the field. This year, there were 219 unfilled emergency medicine spots after the match. Last year, that number was 14. So this is something that's going to continue to get worse unless we find a solution. So people are trying to find out how this could have happened, and people are correctly pointing to the recent proliferation of emergency medicine residency programs. Here are some examples in literature I was able to find of people suggesting that for-profit corporations could be at least partially responsible for this proliferation of residency programs. However, there's been essentially no studies on for-profit corporate involvement in emergency medicine GME, or really any GME for that matter. So that's where we come in. So the objectives of this study were to quantify and describe the growth of for-profit corporations in emergency medicine over the past 20 years, and also determine if there's a difference in resident salaries between nonprofit and for-profit affiliated programs. So for our first objective, to quantify and describe the growth of for-profit affiliated programs over the past 20 years, the way we did this is we acquired a list of all accredited EM residency programs from the public ACGME accreditation database. At the time of this study, that number was 276 accredited programs. We then determined the primary affiliated hospital. The way we did that is we looked at the program name, which is typically the sponsoring institution. And if that sponsoring institution was a hospital, we used that hospital as the primary site. And if it was a university or a consortium, we looked at Doximity Residency Navigator, which told us the site where the highest number of months are spent. And we used that as our primary affiliated site. We then used CMS Medicare data to determine the type of control of this hospital. If CMS indicated that it was proprietary, which means for-profit, we marked it as for-profit. And we determined that 30 of these affiliated hospitals were determined to be proprietary by CMS. So we also searched the internet after this to ensure that nothing had changed between when the CMS data was published and when we did our study. And we found that actually one hospital that CMS designated as proprietary was purchased by a nonprofit, and so we marked that as nonprofit. So in total, we identified 29 for-profit affiliated residency programs, and we also were able to use the internet to determine the corporations affiliated with each of those 29 programs. So once we had that data, we used the ACGME accreditation database in order to determine every new program accredited over the past 20 years. And using this, we calculated the growth of newly accredited for-profit and nonprofit affiliated programs over this 20-year period. So here's what we found. We found that overall, all programs increased by a lot during this time. 117 to 276 over this period, over 100%. In terms of for-profit affiliated growth, we found an increase of over 1,000%. It started at 1 during this period and ended at 29. Now what's interesting is the majority of this growth, around 85%, occurred in the past 5 years. So this is a very recent phenomenon. And in terms of corporate affiliates, we identified HCA Healthcare was the largest, which is not surprising, with 17 of the 29 programs being affiliated with the HCA. The next highest was Tenet Healthcare at 4. So these are mostly HCA programs that we're talking about. So here's a graph of this data. So on the x-axis, you're looking at the year. This is a cumulative graph, so every year we're adding more and more programs. And the gray represents nonprofit affiliated programs, and the black represents for-profit affiliated programs. So you can see everything is pretty steady up until around 2015, 2016, and that's when we start seeing rapid increased growth. So, and that's also the time that we start seeing for-profit affiliated programs for basically the first time. So if you do the math on this, after the year 2015, about 1 in every 3 to 1 in every 4 new programs is affiliated with a for-profit hospital. Here is the geographic distribution of the for-profit programs we identified. What sticks out is obviously Florida. We identified 10 for-profit affiliated programs in Florida. The next highest were California and Michigan at 3. So a lot in Florida, and you can see they're mostly confined to the southern states. So for our second objective, we wanted to see if there was a difference in resident salary between nonprofit and for-profit affiliated programs. So before I get into our hypothesis for this part, I need to explain how resident salaries are determined. So sponsoring institutions receive a variety of funding from a variety of different sources. However, the most important for salaries is DGME funding from Medicare, which so direct graduate medical education funding from Medicare. It's determined by this complex formula, but essentially it's supposed to pay for the direct costs of having residents at your institution, and that includes a salary. So this money goes to the institutions, and there's kind of this black box here where we don't really know what happens and how these salaries are determined. It's usually graduate medical education council meetings behind closed doors. We don't really know how they come up with these numbers. So I was curious what the ACGME had to say about this. So I looked at the sponsoring institution handbook from the ACGME, and I found salary was mentioned on only one line, and so I'll read it to you. The sponsoring institution must provide all residents/fellows with financial support and benefits to ensure that they're able to fulfill the responsibilities of their ACGME accredited program. So this statement is obviously very vague. This is basically the ACGME saying, make sure your residents aren't homeless. Anything beyond that, not our problem. So our hypothesis. Given their obligation to shareholders, we hypothesized that for-profit institutions could be more pressured to extract profit from this lack of oversight, the opaque salary determination process, as well as the lack of negotiating power that residents have due to the nature of the match by reducing resident salaries. So the way we did this is we had our list of accredited programs. The number is slightly different, 269, because we removed Puerto Rico and military-based programs. And then we used actually the program websites. Luckily for us, most programs post their salaries online, so that was easy. We were able to find 189 of the programs, the 2021 to 2022 PGI1 salary, just by looking at the website. Of the 80 that either didn't have information or outdated information, we called them. And we had a slightly under 50% success rate for determining salaries through the phone calls. Overall, we were able to determine salary for 227 of the 269 programs, which is around 84%. So obviously, looking at the salaries alone is not enough. We need to control for confounders here. So we used multiple regression, and we included the following variables. We looked at cost of living index. We used regional price parities from the Bureau of Economic Analysis. This was used in a prior study looking at IM salaries, resident salaries. We looked at the year of accreditation. We looked at program size, program type. We were able to estimate DGME funding per resident using CMS data. And we were also able to use the CMS data to estimate Medicare percent of inpatient days, which is part of that complex DGME formula that I mentioned earlier. So we found that for-profit affiliated program salary is about $4,000 less than nonprofit affiliated program salary. But I wouldn't put too much stock into this number because, again, this is not controlling for confounders. So here's what we're really interested in, the multiple regression results. A lot of numbers here, but this is what we really want to look at, the for-profit affiliated unstandardized coefficient. So what this unstandardized beta coefficient represents is that when you control for all these variables that I mentioned previously, for-profit affiliated programs are associated with about $2,000 less salary. And that was significant with a p-value of 0.01. And in case that's not convincing enough for you, here's a graph of this data. You're looking at the x-axis is the cost of living index that we used. The y-axis is PGY1 salary. And those triangles represent for-profit affiliated programs. And you can see that almost every single one falls below that line of best fit. So these programs really are paying their residents less. Now, some important limitations to mention. We only considered salary. We didn't look at benefits. Benefits could change the total compensation package. We also could have misattributed profit status due to either human error or erroneous information in the public sources that we relied on. We were unable to acquire salary information for all programs. And importantly, we didn't look at contract management groups. That's another modality through which for-profit corporations could be involved in EMGME. So it's likely that our study underpredicted the amount of for-profit involvement in GME. And that leads nicely into our future directions, which is look at CMG involvement in EMGME. These relationships are a little more tenuous, a little more difficult to ascertain using public information. But if a database like that does exist, that would be very interesting to look at. And then also the next step is to really use surveys to determine the subjective experience of residents at these programs. So we identified this almost $2,000 difference, but is that even noticeable to residents? How much does that really, what does that really mean? So using surveys, we can identify additional financial pressures that these residents feel, in addition to other things such as burnout, confidence in skills, overall experience, et cetera, things that numbers wouldn't tell us. So if you zone out on my first slide and you're just tuning back in now, here's what you need to know, the key takeaways. So the past 20 years, but really the past 5 years, we saw a substantial growth of new emergency medicine residency programs. And this is likely a result of the physician shortage scare that happened recently. And there's a call for more programs, more funding, more legislation for new programs. And that's why we're probably seeing that trend. And for-profit affiliated programs also grew significantly during this 5-year time period. They didn't make up the majority of new programs, which I think is important to note, but they did make up a decent amount in the past 5 years. So what happened is it's likely that these corporations found that residency programs are profitable, and it doesn't take much imagination to figure out why a residency program could be profitable. There's obviously funding from the government, cheap labor, it means having to hire less nurses, PAs, doctors. There's also secondary benefits, such as increased prestige for an institution, as well as a pipeline of physicians to hire. So based on probably a combination of those reasons, they found it profitable and they started producing new programs. So we also found that the majority of these for-profit affiliated programs are affiliated with HCA, and they were also mostly located in the South, especially in Florida. We also found that for-profit affiliated programs pay their residents less than non-profit affiliated programs. So we suggest that there should be more oversight over the salary determination process to protect residents. And not only is that the right thing to do, to distribute the profit of the residency program to the residents, but it could actually address the problem at hand here, which is that if we increase salaries, make it less profitable to run a residency program, it would de-incentivize not only corporations, but also hospitals from proliferating at the current rate that they're doing in terms of residency programs. So bring it back to the question that I posed with the title of the abstract, are residents at for-profit affiliated programs underpaid? The answer is, it's a trick question. All residents are underpaid. But programs at for-profit affiliated especially are. Thank you, and here are my acknowledgments. Thank you.
That was a phenomenal ending. This abstract is now open for questions.
Hi, good morning. Thank you for a wonderful talk. I agree with you about the underpaid. Charles Maddow from University of Texas at Houston. Do you have any interest in future directions in looking at any difference between nonprofit and not-for-profit sites?
That's something that we had not considered, but that would definitely be interesting to look at. We kind of grouped it under all one category. Okay. Yeah, thank you.
Thank you so much. This was an outstanding talk. Dr. Promes from Rush University in Chicago. My question is, there's lots of programs that are over the cap for residency spots. Did you guys take into account GME funding into those programs versus institutional contributions, and how did that play into effect?
That's a great question. So that was something that we had talked about. I was actually unable to find the data of which institutions are self-funding these slots versus which are relying on GME funding. But if that data did exist, that would be very interesting to look at.
Good morning, and thank you. Brian Strain from Quia Health in Visalia, California, one of the PGY2s there. In looking at your studies, did you see moonlighting opportunities amongst programs and whether that might have been a variable in determining the baseline compensation for the residents?
No, we did not look at moonlighting actually, but again, that would be very interesting to include in future follow-ups. Thank you.
Scott Gudovitz from South Carolina. Did your data include or analysis in different states and their state income tax? For example, Florida has no state income tax, so does that play a factor in your data?
Yeah, no, that's interesting. I actually never considered that, but that's a good point. But to be honest, I think that would be unlikely to impact the trends that we've seen, just because we did consider all the non-profit affiliated programs in Florida, which is about equal to the for-profit affiliated programs. So you would see that in our graph, that if you look at the same location, they're still different. But thank you for the question.
All right. Thank you, Mr. Lassner. Thank you, Mr. Lassner. That was phenomenal. Our next presentation is titled Early Validity and Reliability Evidence for the American Board of Emergency Medicine Virtual Oral Examination, presented by Diane Gorgas from The Ohio State University.
Thank you, and good morning. Where do I look at my slides? Oh, there.
It's right here. And then you're going to click Bring Forward.
Okay, perfect. Thank you to the SAEM Selection Committee for allowing me to present today in this fourth round of 4 completely non-controversial topics. I'll be presenting on the early validity and reliability evidence for the American Board of Emergency Medicine virtual oral examination. My name is Diane Gorgas. I have no conflicts to declare. I do have a duality of interest in that I serve on the ABEM Board of Directors, and I am also a past or reformed program director of an EM 1 through 3 training program. I do apologize for the glaring typo on this slide. This project is exempt from human research, but as we know, the in front of Ohio State University should be in all caps. So my fault on that one. We all lived it. We all lived COVID, and ABEM lived COVID as well. Because of the COVID-19 pandemic, ABEM's in-person oral exams were canceled from the spring of 2020, and the in-person oral examination has already been found to have substantial validity and reliability evidence. So ABEM had to do a very quick pivot. In the next 13-month period between December of 2020 and summer of 2021, ABEM had a backlog of nearly 4,800 physicians that were waiting to receive an oral examination. ABEM chose to pivot to a virtual format for this, and this study is really looking at the validity and the reliability evidence confirming the use of a virtual oral exam. We chose to look at a multi-trait, multi-method approach for validity, including content validity, construct validity based on Messick's use validity, which really looks at the appropriateness of inferences made on the basis of observed measurements, and also Kane's model of validity, which is a social consequence of the use of the assessment. Kane's model of validity in this instance is really based on the use of the virtual oral exam results to make a certification decision and the use of certification by stakeholder groups, for instance, employers, academic departments, military programs. The reliability measurements that we used were the similarity to the in-person oral certification exam performance, which was also a validity issue. But separately, the Roche reliability coefficient. Really, this is used in item performance. It's a common psychometric study, and it's very similar with a little bit more rigor when it's looking at item response to Chromebox Alpha. The comparisons were done between the spring and fall 2019 in-person oral certification exams and the virtual oral examinations in December of 2020 and then March, April, and June of 2021. The in-person oral certification exam, or OCE, was comprised of 5 single cases and 2 triple case encounters. The virtual oral exam was made up of 6 single cases and 1 structured interview case, which I'll get to in a minute. These were administered via Zoom video communications platform as facilitated through Marquis Media Vendor. Speaking to content validity, all of the virtual oral exam cases used content in the emergency medicine model, and conversely, no content was used outside of the EM model. The EM model, as we all know and love, is put together every 3 years. It has input from extensive surveys, from billing and coding information in emergency medicine, and from an expert panel that, incidentally, that expert panel was convened here at the SAEM New Orleans meeting for the 2020 EM model that's going to be put out. Construct validity was looked at using a post-exam survey. For the in-person oral test takers, there was a 79% response rate for the survey, and for the virtual test takers, there was a 57% response rate. These were scored on a 5-point Likert scale, looking at strongly disagree, disagree, neutral, agree, and strongly agree. The graphs here represent responses. The orange is the response for the virtual oral exam, and the blue is the response for the in-person oral exam. So as you can see, the cumulative of agree and strongly agree to the question. Overall, the cases on this examination were cases that an emergency physician should be expected to see. Totaling results of agree and strongly agree for the virtual was 91%, and for the in-person was 92%. The next question that we asked to assess construct validity was, in my practice, I have seen most of these cases. Similarly, the virtual oral exam had a response rate of agree and strongly agree of 86%, and the in-person oral exam had a response rate cumulatively between agree and strongly agree of 89%. The structured interview is a new assessment format that ABEM is undertaking. It's more of a conversation with the test taker. The structured interview content, just like the standard cases, is drawn from the EM model, which speaks to its content validity. And just to level set for the audience here, most American Board of Medical Specialties have an oral examination, and many of them have exclusively used the structured interview format for decades to really make certification decisions. And this speaks to Kane's validity and also the construct validity. All action steps within the structured interview are really common emergency medicine functions. For example, determining a differential diagnosis, explaining the rationale for ordering imaging and laboratory testing, making a disposition on a patient, etc., and this speaks to the construct validity. From a reliability point of view, the Roche reliability coefficients were often used when applying response theory to an item or to a testing structure. Any level above 0.85 is really considered excellent reliability, and the in-person oral exam in the spring of 1919 was 0.95, and in the fall was 0.93. You can see the Roche reliability coefficients for the virtual oral examinations between December and June. All of them are well above the 0.85 level, and the average of those 4 administrations is essentially equal or slightly better to that of the oral examination in the in-person format. The score ranges also were very similar between the virtual exam and the in-person oral exam, and the in-person oral exam pass rates over a 20-year cumulative period were between 88 and 98%. And the virtual pass rates were between 90 and 95%, so again, very similar. So in discussion, there is strong evidence for both content and construct validity. The Kane's validity model was supported in that ABEM is able to make high-stakes certification decisions based on the virtual oral exam. Academic departments, military, and other employers are able to use certification based on the VOE as rigorous and reliable tools for critical decisions. The reliability of the VOE is excellent. The psychometric patterns were very similar to the in-person oral certification exam. And the ABEM Becoming Certified initiative will determine the long-term format for the initial certification process, but messages you can take home, ABEM will continue the virtual oral exam in the foreseeable future. I'd like to thank the team of expert collaborators that I have on this, Karl Chudnovsky, Kevin Joldersma, Kathleen Ruff, D.P. Goyle, and Earl Reisdorf, and also a big thank you to the ABEM staff and all of the ABEM volunteers that were able to stand up pivot from an in-person oral certification to a virtual oral certification in a speed record time of just a few months. So in conclusion, there is early validity and reliability evidence to support the use of a virtual oral examination format. There is no need to return to an in-person format in the short term, and ABEM has an ongoing research initiative to gather additional validity and reliability evidence. Thank you so much for your attention, and I'd be happy to take any questions.
Trading, UAB. Is the virtual oral exam less expensive to administer, and will that be reflected in the fees for the virtual oral exam?
Thank you for that non-controversial question, and I'm so happy that you asked it. The oral exam is not less expensive to administrate. It really is pretty pricey to be able to give candidates a seamless virtual experience that is both secure and reliable. However, if you're a candidate, you do get to save some scratch by not having to come to Chicago. I will say that. Just to give a perspective on that, of the ABMS boards, ABEM's cost for certification is clearly in the lower half. We actually rank 15th out of 24 when it comes to cost for certification. So we are really trying to keep very tight fiscal control over the costs for raising any certification fees for ABEM, but we particularly have a soft spot in our heart for residents because we were all there once, and we know that that's where the financial burdens are greatest in our careers. So ABEM purposely really shifts the financial burden away from residents as much as we can. Thanks for the question, though.
Hi, Bob Hochberger from Harbor UCLA Medical Center. What was the reliability of the structured interview?
We looked at the reliability overall of the entire test when we were making these reliability coefficients, but the performance of the structured interview, when looking in composition with the rest of the standard cases, is actually exceptional. It has a very different scoring rubric than the standard cases do, in which there is higher variability in the range of the scores. So it actually has a great point by serial and is able to be used even with more power than the standard scores have been used.
Just a comment, that's fascinating, because I remember for the longest time ABEM has been very proud of its reliability because of all the effort put into defining the specificity used by the examiners to score every scoring rating, and hence the pass-fail. And always had concern about the structured interview used by other specialties, surgery for example, where there seemed to be so much subjectivity in a conversation without those specific criteria for pass-fail and scoring. Fascinating result.
Yeah, I'm so glad that you brought that up, and I really would encourage all of you that are kind of wondering what is the structured interview all about. There is a demonstration of a structured interview case on the ABEM website that I would encourage you to take a look at. But the scoring rubric for it is all subjectivity has been removed from the scoring rubric on the structured interview. There's a series of binary yes-no questions. Did the candidate ask this? Did the candidate have a rationale for their decision to do X, Y, or Z? They ordered A, B, or C. What is the therapeutic outcome that they ordered? Yes, no, for each of those. So I think you're right. A lot of conversational scoring rubrics from other boards do have some subjectivity built into them, but that's one thing that ABEM really wanted to avoid. So it's a very clear-cut and I think a powerful scoring system. Any other questions? Thank you so much for your time.
Thank you, Dr. Gorgas. That concludes our plenary session for today. Let's give all the presenters another round of applause. And thank you all for coming. Enjoy the rest of the conference.